Today we have a case of urinary incontinence by Dr. Nishata, OBGPG.
A 70-year-old female, para-3 living 3, sterilized, postmenopausal, hailing from Chennai from low socioeconomic status, came to OPD with chief complaints of involuntary leakage of urine since 2 months, complaints of intermittent leakage around 5 to 10 ml, complaints of associated with coughing and sneezing, no complaints of mass abdomen, leaking is not associated with the desire to pass urine, no history of any excoriation in vulval region, no history of surgery in perineum, vagina, pelvis or abdomen. History of presenting illness is no complaints of mass descending PV. Menstrual history, age of menarche is 12 years, attained menopause 15 years back at the age of 55, previously regular menstrual cycles, 3 on 28 days cycle, 2 pads are changed per day, no clots, no dysmenorrhea, no history of any cyclical hematuria or menuria, no history of menopausal hormone therapy, marital history, married for 45 years back and non-consanguineous marriage, obstetric history, no history of prolonged labor, no history of any operative delivery. P1 girl 42 years NVD healthy, P2 boy 40 years normal vaginal delivery healthy, and P3 is a girl and she's 36 years normal vaginal delivery and healthy. Past history, no history of any diabetes, mellitus, hypertension, bronchial asthma, epilepsy or thyroid disorder.
Okay, what does history of cyclical hematuria or menuria suggest? If there is presence of menstrual blood in the urine, it suggests any intravesical fistulas.
Okay, ma'am.
Okay. And why is the history of prolonged labor important? If there is CPD and prolonged labor, then there can be formation of vesicovaginal fistulas because of the compression of the urethral neck between the fetal head and the symphysis pubis, and that can lead to necrosis. So after 14 to 15 days of delivery, after an obstructed or a prolonged labor, patient can present with vesicovaginal fistulas.
Okay, ma'am. Family history, no history of breast, ovarian, colon or endometrial cancers in family, no history suggestive of BRCA1 and 2 mutations in family, and no history of familial Lynch 2 syndrome. Personal history, no history of reduced sleep, loss of appetite, bowel and bladder are normal. On examination, thin built, moderately nourished, conscious and coherent. Height is 155 centimeters and weight is 50 kgs, BMI is 20.8. On examination, no pallor, icterus, cyanosis, lymphadenopathy, edema, no supraclavicular node. Temperature is 97 and BP is 130 80 mmHg and pulse rate is 86 beats per minute. Thyroid is normal. Spine, no scoliosis, no spina bifida occulta or aperta. Breast is normal. CVS is S1 S2 heard, no murmurs. RS is normal vesicular breath sounds and no added sounds. Per abdomen, on inspection, there is no lump, no ascites, no engorged veins are seen. All quadrants moving symmetrically with respiration. On palpation, abdomen is soft, no mass, no organomegaly, hernia sites are free, and transabdominal tubectomy scar is present. Local examination, genital, labia majora is normal, labia minora atrophic, pubic hair sparse, no excoriation of perineum or vulva. On perspiculum, vagina, cervix are normal, no uterovaginal descent, evidence of senile vaginitis is present. No fistula opening seen on knee, chest or Sims lateral position. On bimanual examination, PV, uterus retroverted, atrophic, mid-position, vaginal wall smooth, no adnexal mass or tenderness. PR, rectal mucosa is smooth, freely mobile, parametrium normal, no nodules in pouch of Douglas, no blood on examining finger. Examination with full bladder. Patient was asked to cough and leak test was positive. Marginal Boni's test was done. 2 fingers are placed in vagina at uretrovesical junction on either side of the urethra and bladder neck is elevated. Patient is asked to cough or strain and absence of leakage is indicative of good outcome after surgery.
Okay, so it is mandatory to examine the patient with full bladder once somebody complains of stress incontinence and also to do a Marshall-Boni's test.
Yes, ma'am.
Okay, so the investigations revealed what?
PAP showed normal smear, USG shows atrophic uterus, ET is 2.5 mm, RFT was normal and CT showed atrophic uterus with thin endometrium.
Okay, so what is urinary incontinence?
It is the involuntary loss of urine.
Yes, which can lead to any social or personal problems and the patient might be aware of it or she can be unaware of it. Okay,
Yes,
explain the epidemiology of incontinence, how prevalent it is.
It is 10 to 30% prevalent in females of age less than 64, 15 to 30% in individuals in a community, and more than 50% in long-term care.
What is the cost?
More than $20 billion a year, mainly protective garment.
Okay, so in the form of diapers have been the cost. Okay, so what is the morbidity and mortality in incontinence?
It is associated with psychological effects such as depression and social withdrawal. Also, it leads to skin infection and sleep deprivation.
Okay, can you explain the two basic mechanisms for pathophysiology of incontinence?
Could be due to bladder hyper or hyperactivity, as well as if there is any outlet obstruction or insufficiency.
Okay, so bladder hyper or hyperactivity is also called as a detrusor instability,
Yes,
and bladder hypoactivity, it can lead to overflow incontinence. Outlet obstruction or insufficiency can lead to urinary retention and dribbling. Okay, so can you explain the control of micturition?
The master control inhibits voiding until it chooses. Coordination micturition is inhibited by cortex. Storage or filling is under the sympathetic control. Beta or beta 3 plus suppresses detrusor, and parasympathetic or muscarinic or cholinergic. Alpha plus stimulates the internal sphincter. Voiding or micturition is by the sympathetic inhibition. Alpha relaxes internal sphincter. Release of parasympathetic, muscarinic or cholinergic stimulation leads to detrusor contraction.
Okay. So sympathetic will cause retention of urine and parasympathetic will cause voiding of urine.
Yes.
And sympathetic is mainly mediated by the alpha adrenergic fibers which are in the internal sphincter. So this is the cerebral cortex. The arc of micturition is under the control of cerebral cortex, mainly in the frontal cortex via the pons. And then these send the inhibitory impulses if the place or time is not proper. And this pontine micturition center switches between the filling and storage and voiding.